Testosterone is a big topic now, especially for young men, and rightfully so, because we have technically a testosterone epidemic at the moment.
Everybody's dying to know about what are GLP-1 agonists, what is Semaglutide, what is Wegovy, what is Mounjaro.
Generally speaking, this medication is started for patients who are in the obesity category.
The study today shows that there's absolutely potential for this Semaglutide to have even more utilizations, meaning in getting off cigarettes and also getting off alcohol.
I'm so glad you brought this up because, like I was saying earlier.
Hey everybody, welcome to Real Mental Health with Dr. Mike Ma, board certified psychiatrist practicing in West Los Angeles. Now, I'm very excited to introduce our guest for today, and I'm excited because this is not just a friend, but a colleague. We work very closely together. We refer a lot of patients back and forth, and that is Dr. Daniel Benhuri. Dr. Daniel Benhuri is a concierge internal medicine and primary care doctor practicing out of the heart of Beverly Hills. Dr. Benhuri graduated from UCLA and did his training in New York at Mount Sinai in internal medicine and primary care. Dr. Benhuri, perhaps one of the first things we'll talk about is what is the difference between internal medicine and primary care? So why don't we start by just introducing you. What's your practice like? What do you do?
Sure.
Let the audience know. Good to see you, dude.
Good to see you. Thank you for setting this all up. I feel so lucky to be here. It's a great show. It's great what you're doing here, man. I appreciate you having me on the show.
Thank you. My pleasure.
First and foremost, I do primarily primary care. For those of you who have an idea of what that is, it's kind of the gatekeeper of medicine. It's basically the person that you come to first when either you don't know what to do or you want to start your medical journey for an acute illness or even a chronic illness or just general ongoing management. And that's something I had a passion for, and I knew that I wanted to do as a physician. A few specialists could do primary care. There's different specialists that can go into that arena. Internal medicine is one of them. And internal medicine is a specific residency that focuses on adult medicine. And we get a lot of training actually in the hospital, which allows us to understand complex medical illnesses a little bit more than a few other specialties and equips us with complex diagnoses and getting a nice holistic approach of a patient. Of adult patients specifically.
Yeah, so internal medicine, your residency, you're doing not just outpatient work, outpatient meaning, hey, I have an appointment, I go see my doctor in his office, I'm there for an hour, I go home, but you also got extensive training in inpatient hospital work.
Absolutely.
So even though right now you're not working in the hospital, your training has seen the whole spectrum, whether it's doctor's visits outside in the outpatient setting, all the way to patients being hospitalized for an illness in the hospital, inpatient. Now, what does your practice look like? So tell us, what does your practice look like?
So at the moment, I'm working in a private office in Beverly Hills. It's predominantly outpatient, which basically means that we only work outside of the hospital. We don't work with patients who are in the hospital with acute illnesses. So most of the patients that come to see me are seeing me for, overall care, their overall care. They want to come to someone who can manage their overall health. And it can be their whole life, it could be their mental health, it could be their cardiovascular health, it could be their weight, it could be their personal stuff. And that's the beauty of what I do. I love it so much is because it involves all parts of the person.
Yeah, it's that your typical family doctor, my primary care doctor, internal medicine doctor, outpatient.
Exactly.
These terms are all used interchangeably, right?
The only difference is family doctor is very specific because it involves children, which I don't usually take care of anybody under 16. And I usually don't deal with like obstetrics or gynecologic issues, which is basically women who are trying to get pregnant. And when they're pregnant, I don't usually manage them.
Yeah, and then you kick those up to like an OBGYN.
Exactly, yeah.
Now, what is concierge medicine? What does that mean? How is it different than your kind of garden variety primary care? What is concierge medicine?
So that's a good question. There's a lot of misconceptions about what concierge is. So the medical field, unfortunately, is fraught with a lot of inefficiencies, and there's a lot of difficulty seeing your physician. whether it's just too much need for physicians, too much demand for physicians, and it's created a lot of like stress for patients, whether they can get access to physicians.
Yeah.
And concierge medicine emerged originally to meet that need, to allow patients, generally patients who are more financially privileged, to access their physician at a more personal and accessible level.
Yeah.
And it's become a little bit more accessible for not even very well-off people. It really depends what type of concierge physician you're looking for. You can find one that's right for you in your demographic or financial situation.
So everyone can relate. Listen,
Yeah.
I'm at Kaiser. I have some sort of insurance. It's impossible to talk to my doctor.
Yeah.
I keep getting the nurse instead. I have no actual way of reaching the doctor. And when the nurse tells me that they're going to send a message to my doctor, it might take like a week to reply.
Exactly.
So what is it like being a patient in concierge care? Like for your practice, do they it sounds like they have direct access for you, but you say more so like patients with financial means.
That's
so I
right.
imagine there's an additional cost there. So
That's right.
What's the added access and the benefit of having a concierge doctor?
So usually there's a membership fee of some kind, whether it's yearly or monthly, and the benefit is you have access to your physician directly. So you don't have the worry of how can I reach my physician? When am I going to see my physician if I need to see them? Whether it's the weekend, the night, doesn't matter. You're able to contact your personal doctor whenever you want.
Yeah.
And that's the specialty that comes with it. And patients are willing to pay for it because it gets rid of that insecurity about their accessibility. And I think that's where the value is, basically.
Yeah, and if you don't mind me asking, I don't know if this might be too intrusive, but like,
That's
what
good.
does it cost? So I've been to your office. It's absolutely beautiful. You're in the heart of Beverly Hills. So what does it cost to have this concierge level care? Because I know you accept insurance.
Right.
So what does someone have to pay in order to access the concierge side of your practice?
The way we do it now is we're kind of leaning more towards a demographic-based cost. That means that people who are more medically intensive, usually we think should cost more versus people who are less medically intensive. And usually that comes with age. So someone who's an 18-year-old is probably going to be less medically intensive usually than a 65-year-old. So we think the cost being higher for an older person, so to speak, is reasonable.
That makes sense.
Yeah, so generally speaking, if you want me to give you a rough estimate, it starts around something in the range of $5,000 a year.
5,000 a year.
5,000 a year.
Now,
But-
what I have found and what patients have told me, again, we share a lot of the same patients because we cross-refer, is that the money that they're spending on their concierge doctor is an amazing investment and the return is immeasurable. If they have some sort of weird lab abnormality or some sort of test they're worried about, they get quicker care. It's helpful in preventing illnesses from progressing.
That's right.
And causing more problems, more impact on your ability to function, more trouble going to work. Now, I have, full disclosure, Dr. Benhuri is my physician. And what I have found is that when I am sick, and because I have this package and this concierge level care, I can get an immediate access to care, immediate access to the medicine I need, and it actually gets me back to work 3-4 days sooner than typical care. So it sounds like a lot, or maybe to some people it doesn't sound like a lot, but the return on investment is fantastic. Again, I got back to work 3 days, I'm guessing, based on like how my care usually goes and how often I'm sick. But I had a nurse come, I got IVs done, I got the Paxlovid when I had the coronavirus, and I got back to work. So it sounds like there's an upfront cost, and there is, but the return on that investment is great. Not to mention if you have an actual medical problem that needs attention, if you're, God forbid, battling something aggressive, having direct access to your doctor and that concierge level care can be literally life-changing. I don't want to be hyperbolic here.
There's definitely situations where it is actually, and I've seen them. And I think if you're a busy executive, you're traveling a lot, you have demanding hours, and you want to feel like you can have access to a doctor whenever you need and not worry about seeing your physician when you want to, it's worth it.
Yeah.
For lack of a better, it's just worth it, I think, in my opinion, as long as it's not a financial burden for you.
Of course.
So I'm glad that you say that. I appreciate you saying that because that's the kind of care I want to give my patients. I want them to feel like, they're getting the care that they deserve, that they need, without worrying about, whether they can get help.
Yeah,
So,
absolutely. Now, we posted on the social media, people have a lot of questions specifically for you. One of those questions that we got repeatedly was, what is it like to work with celebrities, really high net worth individuals, people in high demand? Now, we're going to get to that later. The first thing I want to dive into, being that this is like, a mental health podcast, is you serve as a mental health provider. A lot of patients, the first provider that they'll talk to about their anxiety, their insomnia, their depression, and their ADHD is their primary care doctor. You manage a lot of these patients. So I suppose what I'm curious about is at what sort of severity of symptoms are you comfortable handling? And at what point do you think, hey, I got to kick it up to a psychiatrist?
It's a great question. Like I was saying earlier, our role as a primary care physician is the gatekeeper. So we're the doctor you come to first. So if a patient's having a mental health issue, unless they already have an established psychiatrist, usually, most of the time, statistically, they go to their primary care. And the primary care is actually generally trained to manage most psychiatric conditions within their scope. So I see a lot of patients who are dealing with a lot of anxiety in their life. They might be depressed. They may even have insomnia, which kind of plays into that. And ADHD is also kind of somewhat of an epidemic as well with the adult population at the moment too. So for me, that plays a part in the patient's holistic self. I think their mental health ties into their overall health.
Of course.
And I actually really enjoy taking care of patients who may have mental health conditions. And I generally try to keep it within my scope and not go beyond that, because I think psychiatrists are more, equipped to manage more complex psychiatric conditions. So if it gets beyond my scope, I'll definitely refer them to you or another psychiatric provider. And the point where it gets to that is where I have a patient who I've been managing with a certain medication or certain treatment, and they may not be responding to it, or it's not working for them, or they feel like they're getting worse, or they may need multiple medications. And I think it's more safe and better to manage it with a specialist. I may send it to a specialist because it's better for the patient. Or if they have a lot of psychiatric comorbidities, multiple, I think it's better for the patient to have a specialist like yourself, whether they have complex PTSD, borderline personality disorder, bipolar disorder, schizophrenia. It's better for a primary care physician not to manage these cases. But if you're a patient who's, having a difficult time in your life, you may be having panic attacks, difficulty sleeping, anxiety, and you want someone to help you, a primary care specialist who has experience may be able to help you.
Yeah.
But I think once it starts to get more advanced and you're on multiple medications and you're showing some, complex features like psychosis or bipolar mania, these things, you should see a psychiatrist.
Yeah. And it's very important to realize that, because a lot of patients that are feeling depressed, they're having some sort of mental illness, they'll see their primary care doctor, but they won't think that they are allowed to bring this up with their primary care doctor because, he's a PCP, he's a family doctor, he doesn't deal with this. So one message we can send to the audience is that if you are struggling psychologically, if you're having trouble sleeping, if you're getting anxious or any other trouble with your mental health, it's absolutely appropriate, and we absolutely encourage you to bring it up with your primary care doctor. That is within the scope of their practice. And like Dr. Benhuri was saying, they're very well equipped to treat certain mental illnesses. And if they're not, they're also trained onto how or when do I kick this up to a specialist?
Absolutely.
Yeah.
Absolutely. And as a primary care physician, you need to know your limits. It's very important as a primary care physician to know your scope. Don't go beyond your scope because it might not be beneficial to the patient. You need to know what your limits are.
Yeah.
But if you're comfortable treating something and you have experience in it, that's fine. But you'd have to do what's best for the patient.
Absolutely.
But I agree with you. I think if you're having mental health issues, don't feel like you can't speak to a primary care doctor. If they're understanding and they give you a safe environment, I think it's a good place to start. Because a lot of people out there are suffering and they don't know who to go to. I think primary care is a great place to start.
Yeah. Now, We have the privilege of having Dr. Benhuri here. We got a ton of questions on the social media as to topics that they want your opinion on. So let's get started.
Sure, let's do it.
Something that's trending right now, NAD plus, IVs, drips, supplements. What is the story with NAD plus? Is there evidence behind it? What's the deal? You see a lot of celebrities on NAD plus right now. What's the deal?
So NAD plus is basically nicotine adenine dinucleotide, which is basically in all of our cells in our body. And its primary function is it plays a role in energy metabolism in our cells. But however, in the last decade or so, or even more, we've realized that there may be some therapeutic benefits to administering these medications exogenously, either through an IV or pill form or patch or gel form in some cases. And the main premise of it is to help patients improve their energy metabolism, help with their cell function, cell metabolism, and ultimately help with anti-aging in some way. Anti-aging predominantly. And there is a decent amount of research showing that these supplements could be beneficial to patients, whether it's improving your mental health, actually, potentially your energy, and potentially your overall energy.
So paint me a picture of a patient who is struggling with what sort of symptoms that should then think, oh, maybe I should ask my primary care doctor about NAD+. Like, what does that person look like that could potentially benefit from this medication?
It's a great question. I think a big one is someone who is displaying signs of low energy, fatigue, brain fog, decreased mental clarity, signs of neuroinflammation. So neuroinflammation is kind of a broader kind of term for kind of a process that causes brain fog in patients and could lead to ultimate dementia or Alzheimer's. There's a lot of research going into that at the moment, and NAD and its precursors have shown in research that they could kind of allay these neuroinflammatory processes, and using them regularly could potentially improve these symptoms.
It looks like there's a lot of ongoing research about this.
Yes. Yeah.
So when you let's say I go to you and I say, hey doc, I'm having all these symptoms, I want to look into NAD+. So what does that look like? Is it one IV over 30 minutes? Am I taking a pill every day? What does the treatment regimen look like for initiating an NAD+?
It's a great question. I think honestly, there isn't a current evidence showing that the IV version is better than any other version, although patients prefer the IV version for some reason because they think they're getting a more potent version of the medication that goes directly into your body. And there may be some truth to that because studies show that there's higher plasma levels of the NAD, higher urine levels of the NAD, and therefore they're getting more of that treatment. But there is still robust evidence that the oral version of the precursor of the NAD, whether it's NMN, or it's NR, can also be very useful for patients. And there's certain supplements out there like True Niagen. I don't know if you ever heard of it.
I have not.
Which I take daily, actually. And I've noticed tremendous benefit from it, actually. And I'm not promoting them or anything, but they're actually a great product. Like if you're having brain fog, you're feeling tired or fatigued, or even ADHD symptoms, honestly, the medication really helps.
Wow.
It really helps. And I think I'm not a big supplement guy. I mean, I am in some ways, but I also don't think you should take supplements unless you know what you're doing, what it's for. But this one, I think, serves benefits without much risk.
Okay. So here we have a highly trained, experienced, concierge-level internal medicine doctor in Beverly Hills. What supplements do you take on a daily basis?
That's a good question. I think I have my rotations. I think recently I've been pretty consistent with the NAD supplements that we spoke about. I like to take the oral form, which are basically the precursors of NAD.
Yeah.
They're NMN and NR. And I also take a high-grade multivitamin, which has a proprietary blend in it, which has a lot of different ingredients that I like, made by Mitacor. It's like a medical-grade supplement. I am starting to test creatine and HMB. I think those two have shown promise in, maintaining muscle mass, lean mass, and strength. But those are generally what I take. I like to keep it simple. I don't like to take too many things at once. I think I really like to focus on what actually works.
Yeah.
You know, a lot of people are taking things that are either not good quality supplements or they're actually just not what they should be taking, you know, because it's branded well.
Of course.
Or it sounds good. You know, you got to be careful where you're getting your supplements from.
Now, to the people that say, do I need to take a multivitamin if I have a well-balanced diet? What do you say to these people?
That's a great question. Well, some people think they have a well-balanced diet and they don't. That's the hardest point. That's the hardest thing. So I used to be honest with you, I changed my opinion on this in the last few years. I used to be in this school of thought that multivitamins, you don't need to take them every day and they're a waste. And they're just going to be, you go through your urine and you don't need it, you'll get it from your food. But unfortunately, with the current American diet that we have, a lot of people are not getting the nutrients that they need to function at their optimal level.
Interesting.
So I highly recommend that if you're getting a high quality multivitamin, it's actually more beneficial than detrimental for you.
What does a high quality diet look like?
High quality diet?
Yeah, I think, in which you would have no need for a multivitamin.
That's a good question. The thing is, there's a lot, and we're going to get to this. I kind of like you brought that because there's a lot of fad diets and restrictive diets, which I don't espouse to in the long run. I think a good quality diet is one that takes into account all the essential nutrients you need as a human, whether that's the protein that you need, the healthy fats that you need, the vitamins and minerals. If you're getting that in your diet and you're cognizant that you're getting it consistently, you could be probably okay with not taking multivitamins. However, that's not taking into account the genetic and personal factors that patients have in their own body that they may not be absorbing it well enough.
Oh, fascinating. So just because you're eating the appropriate diet, the absorption might be an issue.
Might be an issue, and that's why you come to me and I test your micronutrients, your total body minerals and vitamins, and you may still be deficient even though you're getting it from your diet.
Fascinating.
And you might be a good candidate for taking supplements without even knowing.
Interesting. So if someone is complaining about fatigue, brain fog, some sort of issue, it's not enough that they have a well-balanced, like Mediterranean diet, for instance, like limiting the amount of refined carbohydrates, drinking enough water, so on and so forth. Perhaps there might be some sort of absorption issue that's not being picked up. And you test for that.
Absolutely.
Yeah.
It's so common. It's very common.
Let me throw this in there because I got a bunch of questions about this. Seed oils.
Yeah.
So seed oils have been vilified in the media and social media these days. What do you say about seed oils? Are they actually bad for you? Do you have a strong opinion about seed oils?
I don't have a strong opinion, but my opinion is that it's just another trend. In my opinion, I think it's just another kind of money-making scheme.
All right, so I'm going to tell my wife that, who just went through all my grapeseed oil out that I paid $24 a bottle for. Damn it, Danny.
I don't necessarily think it's the seed oil. It could be bad quality oil that you're getting from a poor quality supplier.
Is there anything inherently problematic and unhealthy and pro-inflammatory about seed oils?
I think with the current research that we have, there's not enough evidence to prove that.
There's not enough. So why is that a trend right now? Why are people attacking seed oils?
It's a good question. I think there are a little...
And I didn't give Dr. Benhuri the...
That's okay.
I didn't tell him we were going to talk about seed oils, so I'm catching him a little off guard.
No, it's fine. Yeah. I think the main problem here is there may be some evidence that shows seed oils, if they're poor quality, or it could be inflammatory for patients.
Yeah.
But it doesn't necessarily mean that it's something that you should avoid completely. Like I would say saturated fats are worse than seed oils.
What are saturated fats? What are unsaturated fats? Yeah. Can you educate everybody?
Saturated fats, in simple terms, are fats that are solid at room temperature versus unsaturated fats that are liquid at room temperature.
So what's better? So butter is then a saturated fat because it's solid at room temperature.
That's correct.
So are all saturated fats bad for you?
Some saturated fat is good for you. Too much saturated fat is bad for you. You want some. You don't want a lot. A lot is proven to increase your cholesterol, increase your cardiovascular risk. But there is some evidence that it's good for your brain function. But I would say some is good. Too much is bad. However, unsaturated fat that's not necessarily the case. You can have more unsaturated fat and it's safer.
Got it.
So if you want to be on the safe side, you could have more unsaturated fat than saturated fat, even though both of them are somewhat essential in your body.
Got it.
Yeah.
Now, on the topic of diet, there are a lot of fad diets. Keto, carnivore diet. I mean, can we address those two if you feel like there's evidence behind them and whether or not you recommend to patients? And I get it, it's individualized per patient.
Yeah.
But do you have any comment on first keto And I suppose related to keto is the carnivore diet, being that a ketogenic diet means you're severely restricting the amount of carbohydrates. I think it's less than 25 grams a day.
That's right, yeah.
But why don't you comment on keto and then perhaps also carnivore diet and what you think about them?
So in general, I like to say that I don't espouse to any fad diets or any restrictive diets. I actually think they're not sustainable. I think they're not great for human beings altogether because, like we said earlier, they could lead to nutritional deficiencies, energy deficiencies, and all kinds of issues. However, nutrition and diet are very personalized. You can't use a one-size-fits-all for everybody. So in some cases, certain restrictive diets may work for certain people, and you have to tailor it for those people. So for example, you discuss keto diets. Keto diets are pretty heavy in fat predominantly, and some protein and minimal carbohydrates. These could be beneficial for people who don't respond well to high-carb diets, or they tend to gain weight on high-carb diets, and they have a lot of inflammation on high-carb diets. So these keto diets are basically addressing the problem of inflammation because high fat promotes anti-inflammation in the body.
Really?
And so that's why people prefer the keto in some cases. And if you do keto for long enough, it can also trigger some survival responses in the body that can help patients feel a little bit more energetic, focused. Their brains could be more active in different ways because they're relying on ketones more than sugars, which some people say is a little bit more activating for the brain.
Yeah, so what does that mean? So in a ketogenic diet, you're not consuming carbohydrates.
That's right.
But your body needs sugar to operate.
That's right.
Which means that the sugar that's being supplied to your bloodstream is not coming from an exogenous source like your food.
That's right.
It's coming from where? The fat that you're burning in your body.
That's good.
Correct me if I'm wrong, but a ketogenic diet also seems to be a fat-burning diet. Is that accurate? Because where is the sugar coming from if you're not consuming it? Because one thing we do know is your body needs glucose, aka sugar, to operate. Your brain, your tissues, your muscles, everything.
That's
so
correct.
where's the sugar coming from if you're not consuming it?
So generally speaking, you need to be in a ketotic state or state of ketosis for at least 24 hours, if not more. And before that point, your body taps into its energy reserves. So let's say you're not eating any sugar, you're not eating any carbs. Your body's like, oh, shit, oh, crap, we don't have any energy. So it taps into its reserves, which are in the liver. And that's called glycogen, which is basically stored carbs, stored sugar. And so you start tapping into that, and then you're going to have your glycogen storage come out and serve as an energy source. And then ultimately your glycogen storage, if you keep not eating carbs, will run out. And the moment that happens, you have certain mechanisms in place that trigger you tapping into your fat stores now. And now your fat stores, which is called lipolysis, now break down your fats, and your fat serves as energy ultimately, which lead to glucose for the body.
So fat can get broken down into sugar?
Somewhat, through metabolic processes, yes. But sugar then you could still get glucose, but you can still, there's other energy sources that you can get from the fat breakdown, including ketones. And that's why it's called keto diet, because you're getting ketones in your body. And in some organs in the body actually do pretty well with ketones as energy, and one of them is your brain and your nervous system. But other sources are not great, like your muscle, skeletal muscle actually are pretty good with sugar and glucose. So you might actually not benefit too much from a keto-based diet if you really want your muscles to have energy.
So what is the ideal person that should consider a ketogenic diet? Who is that ideal person?
I would say someone who has like gluten intolerance, someone who...
Gluten intolerance?
Yeah, there's a lot of people who do have gluten intolerance. It has to be proven though. A lot of people think they're gluten intolerant and they're not.
So gluten intolerant.
Gluten intolerant patients.
On the extreme end would be celiac patient, okay?
Exactly.
Gluten intolerant.
Yeah, gluten intolerant patients. Patients who predominantly, you can have... it's hard to say. I would never recommend a keto diet. That's the thing.
Interesting.
I would never recommend it. I think I would tailor it for a patient to think maybe they should cut their carbs. Because I think a lot of these diets like keto and carnivore, you can't sustain them for a long time. So I would never recommend them, maybe for a short time, I would say.
On a little bit more extreme than that, and I know we haven't talked about the carnivore diet, we're going to get there.
Yeah.
What's your opinion about fasting, whether that's intermittent fasting,
that's
extended 24, 48, 72-hour fast?
That's a good one.
Do you have much expertise as far as fasting?
I think fasting has become pretty controversial, and they keep going kind of like back and forth about how beneficial it is. But I still think the consensus is that fasting has a lot of benefits.
Yeah, that's my understanding as well.
A lot of benefits, but there is some detrimental effects potentially. But I think all in all, it is more beneficial than negative. And the reason for that is the fasting. When you fast, your body is put in a state of starvation to some extent. And as human beings, our bodies are survival beings.
Yeah.
So we try to survive regardless of what state we're in. And so when you starve your body goes into survival mode, which may release chemicals that help with anti-aging. So and also there's a lot of research that shows calorie restriction and fasting extends life.
Fascinating.
Yeah, and promotes anti-aging.
So perhaps fasting would be a way to promote anti-aging and extend your life.
That's right.
Now, a lot of what we talk about on this podcast is not just psychology, but evolutionary psychology.
Yeah.
So if you think back to, when we're living in tribes in the savannas, hunter-gatherers, our bodies were geared for feast and famine. We would go extended periods of time without eating, and then when we found some sort of like food source, an animal, whatever, we would then feast.
Yeah.
And as we know, evolution takes a very long time, and human development and civilization and agriculture and all these things have progressed rapidly.
Yeah.
Do you think our bodies have some sort of evolutionary basis and are more so wired to have feast and famine?
It's a great question.
Versus this current, it's 2025, we're eating nonstop, there's food constantly available. Is a fasting and then feasting diet more in line with our genetics and the way our body is built? Do you have any sort of comment on that?
I think the answer is yes and no. I think the short answer is yes. The reason for that is if you look at people who fast and then they feast, we see plenty of improved markers, reduced inflammation. In males, we have higher testosterone. We have tapping into chemicals that release anti-aging to allow us to survive. So I think that's great. However, there are some people that it's probably not a good idea to do the fasting, and you have to be very careful of who you're advising to do that. Some people don't do well with that kind of diet. Obviously, if you're diabetic or you have all these kinds of issues or you're on certain medications, I don't recommend it. But for the average person with no medical issues and they want to potentially improve their health, potentially extend their life, and maintain healthy weight and hormone balance, I think using some form of fasting in their life could definitely be beneficial.
Yeah.
And it may take a while to get there. I think with a lot of difficult things, it takes time. So I think fasting doesn't happen overnight. You should do it for a decent amount of time to start realizing the benefits.
Yeah.
So think about it this way. Let's say you're starving, right?
Yes.
You're going to ask yourself, why would your testosterone go up if you're starving, right? And the reason for that is because testosterone is kind of like a hormone that promotes hunting. It promotes aggression, right? So if you're starving, your body's going to tap into your human, evolutionary aggressive side to go get food.
Yes.
So all of a sudden, your hormonal balance is going to shift towards that, and so your testosterone might go higher.
Fascinating.
And that could be beneficial to a lot of guys who suffer from lower testosterone and not have enough energy.
Fascinating. I'm glad you brought that up. Let me kind of digress for a moment. Well, not for a moment. Maybe we'll stay on this.
Yeah.
There's a lot of young men watching this show right now. A lot of them have been fixated and very focused on testosterone levels. Now, could you comment on what are normal healthy ranges of testosterone levels? If I get like a number in the 200s, is that problematic? Do testosterone levels fluctuate? How many times do I have to get a level to be diagnosed as having low testosterone? can you talk on testosterone levels? The audience is very interested.
Absolutely. So
Yeah.
testosterone is a big topic now, especially for young men, and rightfully so. Because we have technically a testosterone epidemic at the moment. And if you look at statistics, if you look
low
at
testosterone epidemic.
low testosterone epidemic in the last 20 years compared to decades prior,
Really?
is that men in their age brackets are having lower testosterone than they did in the previous generations.
Really?
And there's a lot of factors contributing to that. Statistically, we know that increased obesity rates are largely contributing to that. Poor diets, increased stress in our lives, the influence of internet, social media, and all these things are contributing to that as well. Is this important? That's the real question. Does the number really matter? I think the real answer is it depends, because it is just a number. I have a lot of guys that come to me in my office and they're feeling great. Their sex life is great. Their exercise is great. Their energy is great. But their testosterone is probably not in the range of what's considered optimal.
Which is what? What are the range? Yeah.
So optimally, literature says that you should peak in testosterone around from 18 to 30, somewhere in that range. Usually teenagers are known to be very high testosterone. They're going through puberty and they're becoming adults. And that range, in that bracket, 18 to 30, your testosterone should probably be somewhere from like 600 to 800. Sometimes up to 1,000 is considered normal even. And then from 30 to 45, you can say 400 to 600, 400 to 700 is normal. And then 45 to 65, I would say 350 to 600. And then after 65, 250 to 450.
So average testosterone levels reduce over time and as you age.
That's correct.
And then I got you a bit off track. So you're telling me, first of all, like every good doctor, there's no like broad strokes here as far as every individual patient is different.
That's right.
And just because your testosterone is low does not mean that is the culprit behind all of your symptoms
That's exactly
and problems
right.
and complaints. Dr. Benhuri is presenting an example of a patient who is feeling well, robust sex life, high libido, and yet his testosterone might not be very high. It might be even low compared to the normal range.
Absolutely.
Testosterone level, it's important. Don't put too much stock in it. It is one metric, but don't put all your eggs in that basket. Is that fair?
That's correct. 100%. It's one piece of the puzzle.
Yeah.
Don't get me wrong. There's people who do suffer from low testosterone, and that's something that we should address.
Yeah.
And there's different ways to address it. But the overwhelming majority of the time, especially if you're a young, healthy male, if you have a low testosterone, it's probably caused by something else. There's usually nothing wrong with you.
Like what? What can cause low testosterone levels?
Great question. So traditionally, certain medical conditions cause low testosterone for people, including diabetes, thyroid issues, profound obesity. And there's definitely certain medications that lower your testosterone, especially in the psychiatry class of medications.
We'll put a pin in that and get to that.
Yeah,
later,
which is very important for physicians to know. However, common every day-to-day things can really affect your testosterone.
Like what?
So, in the world we live in, there's tremendous amount of stresses in our lives, work stress, financial stress, relationship stress, parenting stress. This stress and pressure, which may lead to anxiety, poor sleep, poor appetite, poor diet, all of these together can affect your testosterone levels and are usually considered the main cause of your suboptimal testosterone
Chronic
levels.
stress, insomnia can lead to low testosterone levels.
Absolutely. The two predominant causes of low testosterone in a young, healthy male in our generation is chronic stress, poor diet, and obesity.
Fascinating.
By far. You could even argue obesity is probably number one.
What are some natural ways, without medications, to increase your testosterone? Let's say, okay, clean up your sleep, adjust your diet, try to address the stressors in your life, the chronic stress. Are there any other ways that we can increase our testosterone levels?
Without medication.
Without medications?
Absolutely.
Like what?
The number one way I would say is if you're overweight or obese, focus on losing weight. The reason for that is when you're obese or overweight, you have more fat cells or larger fat cells, and that promotes estrone. which is a hormone that's pro-estrogenic, and that can reduce your testosterone levels and decrease the function of your testosterone, which will lower your testosterone.
Okay, so in fat cells is some sort of enzyme, or there's something happening in fat cells that converts testosterone to estrogens? Is that what you're saying?
No, it's more the adipose cells, which are fat cells, that are in the body. If there's too much of it or too much abundance of it, it can promote a hormone called estrone, which could basically lower your testosterone levels.
Fascinating. So being too fat and having too much adipose tissue, which is fat tissue, can lower testosterone levels.
That's
so
right.
One way to increase your natural testosterone is by losing weight.
That's correct.
If you're obese.
Which goes to my next thing, which is exercise.
Exercise.
So number 1 is weight loss. Number 2 is regular exercise.
What kind of exercise? Is it like long distance cardiovascular exercise, weight training, interval training with intensity? Is there any evidence as to what sort of exercise will increase testosterone levels the most?
The most, I would say, definitely resistance training of your big muscle groups, like your quadriceps, your buttocks, your thighs, your chest, your back. Working on those muscle groups, putting stress on them will promote a testosterone boost. But you have to make sure not to overwork them either, because you can also deplete your testosterone if you overwork your body. So I see a lot of guys come to me, they're bodybuilders, and they're huge guys, like Arnold built guys, and they have low testosterone. And the reason for that is they're overtraining.
Or exogenous hormone use, but we'll get to that later.
That's true too.
Yeah.
That's true. You got to be aware of those things too.
Yeah.
So you got to make sure you hit the sweet spot when it comes to your testosterone. Make sure you're not undertraining or overtraining. An hour a day or an hour every other day is very healthy. And adding cardiovascular training is also very important too, which has an added benefit of cardiovascular health and mental health too. Which can help promote the testosterone as well.
Yeah. Now let me pick you up on something you said. Psychiatric medications that may reduce testosterone levels.
Yeah.
Can you speak on that?
Yeah, there's certain medications that patients may be taking for their psychiatric conditions that could contribute to low testosterone.
Like which ones?
Specifically, patients who are taking antipsychotic medications. So if they're being treated for bipolar or schizophrenia, you should be very mindful of what they're on. Newer generation or older generation antipsychotics can lower your testosterone. But even like some of the everyday medications, like even Seroquel, for example, for sleep, that can affect your hormone levels that you should be mindful of.
And if anybody has any questions as to antipsychotics and potential negative impacts on testosterone, leave comments below and then we can link you with some more information, some evidence.
Another one is there are some medications used for heart failure, or they're used for acne.
Is there one classic example of a medication that people are taking that is reducing their testosterone they should be aware of? Is there one that stands out from the rest?
I would probably say like Risperdal or Risperidone, that kind of medication.
He's talking about an antipsychotic medication that one of the side effects has to do with prolactin and other hormones that regulate our sex hormones.
That's right. That's classic, I would say.
Yeah,
that's classic. But you don't see a lot of people on it, obviously.
Yeah.
But if you're in a niche, area, and there's a lot of patients who are on that, you should definitely be mindful of that.
Yeah, and antipsychotics like Seroquel, those have the potential to have big time metabolic side effects.
Definitely.
Which include insulin resistance, which include gaining weight, increased
which
waist
indirectly leads to low
testosterone, gaining fat tissue, which of course then leads to an increase in estrogen and female sex hormones and a reduction in testosterone. Let's go on to the next topic.
It was a great topic. I love it.
Another thing everybody is dying to know about is the GLP-1 agonists. What are GLP-1 agonists? What is semaglutide? What is Wegovy? What is Mounjaro? So if you could just start with a basic education to the audience with all those fancy words I just used.
Sure.
What are these things? What's the difference between them? What do they do and who are they good for?
Sure. Great question. This is a big topic now. Everyone's very interested in this class of medications. They're called GLP agonists. Traditionally, they were actually developed to manage diabetes with their blood sugar balancing activity. Actually, ironically, they originally found this medication as a derivative of a substance that was found in lizards, actually.
Really?
Yeah,
Lizards?
Lizards. Yeah, so there was a lizard that, I forgot the name, I'll be honest with you, that was found to feast once a year and live without eating for an entire year, or 6 months or to 12 months. And they wanted to study why this lizard was able to live without eating. And what they found was there was an incredible amount of GLP in this lizard. And they wanted to realize, why was this GLP in this lizard allowing it to not eat but still survive? And they thought maybe this could be a therapeutic kind of treatment in humans. And as it turns out, this GLP peptide can actually serve to reduce appetite and manage blood sugar levels, and also allow you to survive without eating for prolonged periods of time. So ultimately, it became a modality for treating diabetes in humans. There's a few early generation GLPs, like liraglutide, and those that have kind of expired. And there's two GLP agonists now that are predominant in kind of the medical world now, and it's semaglutide and tirzepatide.
And so these are the two up-to-date new GLP agonists.
That's correct.
Okay.
And so semaglutide is the peptide that's found in what people traditionally know as Ozempic. And now there's one called Wegovy, which is for obesity.
Yeah.
Then you have tirzepatide, which is not only a GLP agonist, it's also a GIP agonist. So it's a dual peptide agonist. And it's the peptide that's found in Zepbound, which is an obesity medication, and also Mounjaro, as many people know for diabetes. So these medications are very multifaceted. Although they were originally used for diabetic patients, they have served to help patients lose weight and manage their obesity, and they're very effective at that. And I think their benefits to risk ratio are largely very favorable for people.
Really?
Which means that they're very effective at helping people lose weight. And the risks are largely, symptomatic, so to speak. So we haven't seen much evidence that this is detrimental to people's health, unless rare circumstances.
Yeah.
There's rare circumstances that people do have dangerous, reactions to medications. It's like that for every medication on the market. So that's not the status quo.
Okay, so GLP-1 agonists, they're regulating blood sugar.
That's right.
They're reducing the hunger feeling, so you can go longer without eating. Is that right?
That's right.
Okay, and no major side effects. Now, the problem that I've heard is that once you get started on these things, once you are discontinued off these medications, you have a rebound increase in the weight that you've lost. So what do you say about these medications getting dependent on them to maintain or to lose the weight and then maintain your weight, and the risks of gaining it all back when you discontinue these GLP-1 agonists?
That's a great point, and everyone worries about that. They come to my office, they're like, oh man, if I want to get on this medication, am I going to gain weight right away? It's not necessarily true. It really depends on the case. So just like I said earlier, every treatment should be tailored for a person. So there's definitely cases that you get on this medication, you lose a ton of weight really fast, and you come off the medication and you do gain a lot of weight. But there are situations where you get on it and you slowly taper off the medication and your weight is a lot lower than where you started. And that's the goal that we have. And that's why it's important to consult with your physician before starting these medications, to create a plan of action, basically.
So your own personal experience, anecdotal experience, how much success do you have starting a patient on one of these GLP-1 agonists, having them lose their weight to get to whatever their goal is, slowly tapering them off, and having them maintain that goal weight after they've been fully discontinued off the medication? Your own personal experience with your patients. How is it going?
I will say off the bat, if you are a long long life, how do you say this? If you are lifelong like person who's been obese their whole life, even from childhood, teenage years, your parents are obese, your grandparents are obese, that is very difficult for your body to overcome. And in those cases, I think coming off the medication is probably not the right decision. I actually would keep those patients on the medication. And evidence shows that keeping them on the medication is recommended, and you shouldn't take them off because the higher chances that they're going to gain all their weight back. That being said, there are people who are not lifelong obese patients or overweight patients, and throughout their life, throughout the years, they've gained weight, and they want to lose weight, and they want to use these GLP medications as a tool, and that's very effective, and it can work for people. And I see a lot of patients like that, and I put them on the GLP medication for about 6 months, maybe more, and sometimes they want to come off the medication, and we slowly taper them off, and we are very on top of their lifestyle and how they've modified their lifestyle since they've been on the medication, and that helps them sustain their weight loss.
Yes,
I would say statistically, at least 50% of my patients that have tapered off thus far have been successful in maintaining their weight off.
Wow, that's amazing.
However, there's higher likelihood of success of coming off the medication if you've been on the medication longer. So if you've only took the medication for a short amount of time and you quickly come off of it, there's a higher chance that you're going to rebound that weight.
That's fascinating.
Yeah.
What I've seen is patients that are started on medications like this, where it reduces their hunger, it allows them to then work to build healthy habits as far as diet and exercise. Yeah. And the longer they're able to maintain these healthier behaviors,
exactly,
the more they can get, formed into habits, and the more success they have of maintaining these habits once the medication has been discontinued.
That's right.
Now, a question for you. What is the indication for starting this medication? Meaning, what do you need to see in someone where it's medically appropriate to start the medication, and I suppose also medically appropriate for the insurance to pay for it? So what are the indications? Who shows up, and what do you need to see in them for them to be started on this medication?
That's a good question. You mentioned insurance companies, so that's interesting because the qualifications for insurance companies are actually separate from what the actual manufacturer is.
Interesting.
And that creates a problem, which I'll talk about later. So generally speaking, this medication is started for patients who are in the obesity category, which means their BMI is above 30. Which for most people, it's appropriate to say that their BMI above 30 is obese, but not in all cases, because some people may not be obese and their BMI is above 30, and you have to be careful.
Of course, a lot of muscle mass.
A lot of muscle mass. Yeah, exactly.
Heavy weight, short stature,
Exactly. Or if your BMI is above 27 and you have multiple comorbidities, such as high cholesterol, pre-diabetes, fatty liver, or some other medical condition that's increasing your overall health risk, you may be considered to benefit from these medications. However, we usually don't recommend starting these medications right off the bat unless you've tried weight loss from other measures, non-medication measures, whether it's diet changes, calorie restriction, exercising, at least for 6 months to a year, and you've been unsuccessful, then we're like, okay, let's try some medication to bring your weight down and improve your health. That's the candidate that we look for, basically. So I really like using the medication because I see how much it improves people's health, how much it improves their lives, and I love practicing that kind of medicine. And I think it's a great thing that's come out in the medical world.
How often do you see people abusing it? Now, here's where our worlds might collide, is patients that have body dysmorphia, anorexia, bulimia, disordered eating. How often in your practice, mind you, the man's in Beverly Hills, this is LA, this is Hollywood.
It's true.
There's a lot of people that have trouble with body image and they have disordered eating. How often do you see somebody come to you seeking these medications to utilize them in like a pathological, self-destructive, unhealthy way? How often are you seeing that?
All the time.
First of all, how often do you see that? Second of all, how do you approach the conversation with the patient as to why you won't prescribe it and what's going on with them?
That's a great question. I think it depends on the case. To answer your question, I see it all the time, multiple times a week. I see young females.
Multiple times a week.
Yeah, multiple times a week. There may be a normal weight or in some cases even underweight, and they want to get on the GLP weight loss medications. I refuse to give the medication to them because I think it's not safe for them. However, there are some situations where people are in the normal weight range, but they're approaching overweight and they're really struggling to lose weight, especially if they're menopausal or premenopausal, and they're really struggling to keep their weight in check despite calorie restriction and those kind of things. I do sometimes help patients, with the weight loss medications. I do help them. But usually if they're not meeting the criteria, I have to tell them, I think this medication is not the right fit for you. And I think it's not, safe for you to be on this medication, given that your weight is not overweight and you're underweight. So I don't consider them as good candidates for that. Yeah. But I see it all the time. There's a lot of vain reasons why people want to lose weight, and they come to me to help them with that. And
What are some common side effects of these GLP-1 agonists?
The most common side effects are largely gastrointestinal, especially when you first start the medication or the first few days of injecting the medication. You may get nausea, you may get acid reflux, stomach upset. Some people complain of bloating, constipation, and in some cases diarrhea on the higher doses especially. Also some miscellaneous side effects like fatigue, headache, body aches do occur with some patients. It's generally considered that the second class of medication, tirzepatide, generally has a little bit.
That's your Mounjaros.
That's the Mounjaros have a little less side effects, although anecdotally it's not always the case. And semaglutide has a little bit more gastrointestinal side effects, but also the tirzepatide is also considered to be more effective than semaglutide. So
interesting.
That's another thing.
So if, let's say your cousin was coming to you and they were obese.
Yeah.
The tirzepatide versus the semaglutide. The tirzepatide, your Zepbound, your Mounjaro, is that a better medication than the Wegovy's, aka the semaglutide?
It's a great question. I don't want to put down any Wegovy or semaglutide people out there or companies out there because I think it's a great medication. If you're morbidly obese or you're very obese, I actually, ironically, paradoxically, would recommend starting them on the semaglutide, which is considered the less potent of the two. And the reason for that is I want to max them out on the semaglutide before I give them the higher one. Because if you put them already on the tirzepatide, the higher version of the medication, you have not many places to go after that. So I want to maximize the semaglutide on the patient. And if they get to a point where they plateau on their weight loss, then I'll switch them to the tirzepatide.
Fascinating.
I've learned that is the most effective treatment for very obese patients. Yeah, and they do very well in the long run. So to answer your question, I would say the tirzepatide medication is better for the long run for patients' weight loss management. Yeah.
Okay, so on the topic of semaglutide, actually, there was a paper released in JAMA recently talking about the effect of semaglutide with reducing alcohol consumption or alcohol cravings in patients that have alcohol use disorder. So for the audience out there, the paper is titled Once Weekly Semaglutide in Adults with Alcohol Use Disorder, a randomized clinical trial. So let me read some of the main points from this, and let's hear what you have to say. So some of the key findings from the study, that the participants in the study reduced alcohol consumption, reduced drinking intensity, not frequency. So the times that they had alcohol, they drank less of it, and they craved alcohol less. Interestingly, in the study, they also found that some participants who smoked cigarettes, they had less cravings and actually less reduction in, or more of a reduction in cigarette use per day, so less smoking of cigarettes. So what this study shows is that there is absolutely a place here to further investigate semaglutide for alcohol use disorder and potentially cigarette addiction. Brand new study. So this medication, it seems like a wonderful medication. We talked about the symptoms as far as potential side effects. Now, there's other scarier side effects out there that are very rare. If you guys are curious, leave questions in the comments. We can get to that. But the study today shows that there's absolutely potential for this semaglutide to have even more utilizations, meaning in getting off cigarettes and also getting off alcohol. Fascinating development literally this month.
I'm so glad you brought this up because, like I was saying earlier, I do love using these medications for my patients because they have so many benefits outside of just weight loss. And I've seen in most of my patients, their alcohol consumption has come down dramatically after using these medications.
Fascinating. You've seen that in your own practice.
Absolutely.
Alcohol consumption reduction.
Substantial.
On semaglutide.
Instantly.
Really?
Instantly, they lose the interest of drinking. And some cases just cut down dramatically, where they're not excessively drinking, but they can drink at the level that they feel good.
Fascinating.
Yeah.
So this study came out and it confirms your own anecdotal experience with your patients drinking less alcohol when on this medication.
That's right.
Amazing.
And more so, it's showing even more benefits that we're starting to realize, including improved menopausal symptoms in women who have hot flashes. I've learned this in my practice indirectly, and recent studies have proven that women with menopausal symptoms actually improve on the semaglutide and tirzepatide. They smoke cigarettes less. And generally speaking, if you want to put like an umbrella around these medications, I would say that they reduce the desire for cheap dopamine. Cheap dopamine. The unfortunate collateral from that is that this can sometimes reduce someone's sex drive, which in some cases could be a negative side effect, and people can have reduced sex drive, and that can impact their relationship, their marriage, and their overall kind of like sex life. That's the negative side of that, but the positive side is you partake in less kind of destructive behavior, such as drugs, alcohol, smoking, risky sexual behavior, but also think about how it may affect someone's relationship if you reduce it too much.
Interesting. So you ask about someone's sex drive and libido when you start them on this medication because a reduction in libido, aka sex drive, is a potential side effect of these GLP agonists?
Fortunately, I don't see it that much in my patients, and most of my patients don't complain about it, but the literature shows there is a decent amount of evidence that shows that it can lower libido in some patients. Not many of my patients have complained about this as like a side effect and a reason for them to stop the medication. But if you're a provider or a physician who is prescribing this, you should be mindful of that prior to starting the medication, so that if a patient already has hypoarousal disorder, a low sex drive, this medication might even further lower that. So I don't necessarily ask them, but I may advise them that this might be a potential side effect.
Fascinating. Let me ask you another question. So a lot of patients come to me, they say that their sex drive is low. So I know how I approach that from a psychiatric perspective, but are there any agents or medicines out there that help boost someone's libido? Let's say their testosterone is fine. Let's say they're sleeping fine. Their complaint is low sex drive. Is there anything out there that helps boost libido right now?
Absolutely there is. It depends on whether you're male or female. It goes without saying, the first thing to think about is a patient's lifestyle, right? You got to look at their lifestyle, what's their relationship like? Are they having relationship issues?
Of course.
The stress between partners can be the primary drive in your sex drive issues. That's the first place you got to look. And a lot of people forget about the key glaring, issue there.
Yeah, of course.
After you've ruled that out, you have to look if there's actually any other chemical reasons for that, whether hormonal reasons, do you have any deficiencies in thyroid hormone or testosterone, estrogen, anything that could be medically causing them to have low libido. The overwhelming majority of the time, if they're young and healthy people, their low libido is having to do with their psychological status, what's going on in their life, their stress, poor sleep, poor lifestyle. That's probably the main thing, or even relationship issues. But regardless, you can still address those problems with different treatments, like you're asking me. For men, even the taking of a daily PDE agonist, such as like Cialis or Viagra, just the daily intake of that could improve their testosterone. Even
their
the daily
libido.
Intake of like a Cialis or a Viagra could improve your sex drive as a male.
Yeah. It's a fascinating point because I don't think a lot of doctors know this, but these Cialises, these Viagras that are mostly a plumbing issue. They open up the vasculature and the vessels to allow someone to get and sustain an erection easier when they're sexually aroused. There is actually a bit of central action with these medications, central meaning like in your brain, to increase sex drive and libido. It's minimal, but a lot of providers don't realize that these things actually do have a bit of central action. Let me ask you another question. A lot of patients ask me this, men and women. I know my answer, but hey doc, what does a normal sex drive actually look like? How should my libido, what is a normal male or female libido? Like, what am I comparing this to? So what is your answer to what is a normal sex drive for a man and or a woman?
That's a tough question because it's so individualized. It could be different per person. So I would say the answer is if it's less than where you want it to be and it's much lower than where you want it to be, within reason. You know, if you're someone who's used to masturbating 3-4 times a day and now you're masturbating 1 or 2 times a day, is that really a reduced libido? It's hard to say. It sounds like you're okay, you know? But if you're saying that you normally, you know, have a sex drive every day and you want sex every day, and all of a sudden you don't want it for months, that's clearly a low libido. And the question is, how much is it affecting your life? That's the most important thing. Is it reducing your relationship satisfaction? Is it reducing your quality of life, your health? Then we really need to discuss what are some treatments for that. The interesting thing is there are some peptides that are out on the market now that are FDA approved for improving sex drive that a lot of people don't actually know about. There's a medication called PT141.
PT141.
PT141, which is a peptide that's FDA approved for females for low libido, especially women who are menopausal. And what it does is it basically stimulates the melanocortin center of the brain, which indirectly improves the libido of a patient.
Fascinating. Females?
Females is what it's approved for, FDA approved for, but it actually works in both genders. Male and female, and actually I predominantly use it in my male patients because they want something to boost their They want something that can boost their sex drive without taking testosterone or Viagra or Cialis, and it's really effective.
Now, is that an injection? Is it a pill? How often do you have to take it? How long does it work for? PT141.
So PT141 is recommended to take up to 2 times a week. You don't want to take it more than that. It has the side effect of actually causing bronzing of your skin or tanning of your skin because it's triggering your melanocyte center.
Is it an injection, a pill? What is it?
It's a injection, subcutaneous injection. So it could be your lower abdomen or thigh, just like how you would take the weight loss medications like GLPs. It could cause the side effect of flushing for some patients, but it works instantly. It can work in 1 hour after using, and it helps with erectile dysfunction. It helps with desire. However, only lasts 2 to 3 days. So you should use it, you know, up to twice a week to help promote sex drive. And most people use it as needed. They're not using it regularly. They're using it to help boost their sex drive, you know, when needed.
But I suppose there's some planning involved because they have to come to your office and actually get an injection. So it's not like they can just inject themselves, you know, Friday afternoon before they start their weekend. They need to make an appointment with your office. Unless, am I wrong? Is it a take-home syringe, or do you have to go to the clinic to get it injected?
Most of my patients take it home.
Oh, they do take it at
so
home.
They're able to use it when they need it.
So you have to give them an education on how to shoot themselves with the medication?
Exactly, and it's very easy to do so. Once you figure it out, you could do it on the go. You could do it anywhere. Yeah.
Now, do you have any here for me to take home as a sample?
Not today, but next episode.
And if I squirt this into my wife's coffee, will it still work that way?
I think you're going to have a great weekend with that.
Okay, now on that note, Viagra, Cialis, your PDEs, as you called them, do these work in women, or is it just men because of, you know, getting them to like get and sustain an erection? Can women benefit from taking Cialis or Viagra?
It's generally considered that we don't give these to females. It's not targeted for females. It doesn't work the way it does on females because the main premise is to improve erections. You're basically improving blood flow to the groin of males to improve their erections. So I wouldn't advise females taking it.
Now, I have heard the opposite, and I actually do sometimes prescribe females.
Oh, yeah?
Because I believe it also increases like clitoral engorgement, making the clitoris more sensitive and more easily aroused during sex. So I personally will prescribe these in females.
Interesting.
Very infrequently. How many times have I done that? Probably less than 10. And how often has it been effective? Maybe half the time. But some psychiatrists will prescribe these for females.
Oh, really?
Off-label, being that they're only indicated for male patients.
Interesting.
Yeah.
I got to read the literature on that. I maybe don't know that, but I'll look into that. Maybe it is something that's useful for females. It's just generally not indicated in females. It might, because it's not a hormonal-based medication, you might be right. Maybe it is improving blood flow for women too, and that might improve their libido as well.
Yeah.
I haven't looked into it that much.
Yeah. Now, I don't think there's literature. I think it's off-label.
Off-label,
Again,
yeah.
even if it's off-label, I don't know if there's a robust literature out there for it. And I've done it so infrequently over the duration of my practice, maybe up to 10 times. So something to look into. And if there's any women watching that are interested in that and want more information, leave a comment. We'll get to that. Happy to provide sources.
It's a good idea. It's a good question. I'll look into that. I think it's definitely an area to look into.
Yeah. We're running out of time. I'm going to end by asking you, if you were to give the audience just one piece of advice for physical and mental wellness, what would that advice be? And after that, let's introduce people to where are you? How can they get a hold of you? What is your website? And if they want to book a visit with Dr. Daniel Benhuri, how they can do that.
So my basic piece of advice to everybody is get the basics down right. Mm-hmm. Forget about supplements, forget about, fancy treatments. If you're not getting the basics down right, you're already a few steps behind. Mm-hmm. What do I mean by that? I mean, get your diet right, get your stress down, get your sleep right, and make sure your weight is in check. Mm-hmm. If you don't have those things in order, then any supplementary treatment is not going to do that much because you're already at a disadvantage from a health perspective. Mm-hmm. So get your basics down first, then focus on supplements.
Yes.
So if you're getting shit sleep, you're chronically stressed, you're not exercising at all, you're eating shit every day, Cheetos, fast food, and all this crap, taking an NAD supplement or taking any supplemental treatment is not going to do much for you in the long run. That's only if you're trying to optimize your health and you've already got the basics down. So I would say start with the basics, optimize your health with that, then focus on the augmentation part. Mm-hmm. Secondly, I would say it ties back to mental health, what you're saying. Mental health ties to your health. People who are more mentally unhealthy, depression, anxiety, chronic stress, they have more medical illnesses, cardiac illnesses, dementia-based illnesses, shorter lifespans, strokes. So take care of yourself. Mm-hmm. Everything in the body is connected to each other. If you're not feeling well mentally, your body's not going to feel good. So take care of your mind, take care of your body, and then go to your physician and ask them is there anything you can do to optimize your health? And that's where I come in, and I can help augment your health, augment your treatments, and see if we can potentially improve how you're feeling and improve longevity, potentially. Yeah.
And let me just throw something into there as far as the basics. Also, stopping any sort of habitual drug and alcohol use. I would say that is also my recommendation as far as get the basics in play.
Absolutely.
If you're drinking and smoking every night or several times per week,
absolutely,
reducing the toxic substances that you bring into your body also, I would say, goes along with the basics.
You're right.
Now, Dr. Benhuri, how do people come see you? How do they get an appointment with you? What is your website? Tell the audience, please.
So my name is Daniel Benhuri. I'm an internist and concierge doctor in Beverly Hills. I'm at 9400 Brighton Way. I'm Beverly Hills. You can call our office at 310-362-1255. And you can also go to my website at danielbenhurimd.com. You can make an appointment there. You can message us. And we're easy to access. And we'd love to see you.
Yes. And last audience question. He is just as good looking in person as he is on camera.
I don't know about that, but thanks for that.
Dr. Benhuri, thank you for coming. We will link your website down below. And please come back and see us again soon. Thank you.
Thank you, man. I appreciate it. It was a great time.
All right.